Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, do you have...
Thank you, Maren. My name is Norm Thurston, Executive Director here at NAUTO, and I'm pleased to welcome you all to our second Igniter session for our 36th Annual Conference. Today's topic will be hospitals and homelessness, creating a reliable indicator of homelessness using Kentucky's health facilities and services data. Our presenters will be Matthew Walton and Allison Lile from the Kentucky Cabinet for Family and Health and Family Services. We also want to recognize Milliman MedInsight, one of NAUTO's collaborating partners, who is sponsoring our Igniter session series. Let's go ahead and welcome Matthew and Allison to the stage.
Hello.
Hey, Matthew, Allison, it's good to have you guys with us today. Let's go ahead and start with could somebody just give me an introduction as to why homelessness in hospitals? What's the big idea behind all of what you're talking about?
Sure. Thanks for having us today. And the big idea here was we were aware that there are people that are in Kentucky's hospitals that they don't have a safe place to discharge to. So, and that this creates sort of human suffering. As you can see on the image there, this is actually a real image of a place where community health workers in Louisville, Kentucky, were outreaching to a person who had been discharged from a hospital. This is not an exaggerated image of where people go when they've had been hit by a car or had some exposure to the elements or had some medical or surgical intervention in a hospital. So a community organization reached out and said, could you help us estimate how often this happens around the state? That's the big picture.
Yeah, so the idea is, first of all, just to get a handle on the prevalence of these discharge issues, how much homeless care is being given in hospitals and people who don't have necessarily a place to go to. Why aren't they just discharging them to nursing facilities or other kind of places like that? What are some of the issues there?
So the first response would be that does happen, and I think that this is probably many of the folks in the audience, if you've spent time around trauma facilities or hospitals, that oftentimes that a nursing facility or a rehabilitation center is a maybe least worst scenario for someone who doesn't have a proper house to go back to. The question is that always necessary? Is it always a good use of public dollars? Those tend to be some of the more expensive health interventions that are available, and a lot of times we'll talk about it a little later. We ask questions like, well, who insures these individuals? Kentucky is a Medicaid expansion state, so we found that it's largely public insurance. Medicare and Medicaid are big organizations that provide healthcare financing to this group, and so we thought, if it's not necessary and it's expensive, and there are other models out there around the country, maybe that the project that we are talking about today could lead to informing a sort of Goldilocks, lower cost and sort of higher return. And the image you see here is actually, that's Dr. James O'Connell. He helped found an organization called the Boston Healthcare for the Homeless. And that image that you're seeing there on screen is him standing with a nurse in a medical respite facility. And there were two organizations that partnered with us that kind of approached and said, could we make a request of our publicly, the public use data that Allison is the administrator for in our cabinet, to see if Kentucky could try to do some of the things that bigger cities like Boston, like Los Angeles, several other big metro areas around the country have established. And medical respite was one thing we think may be sort of helping an answer to that question of, well, if a nursing home is too expensive and the street is just not humane, maybe there's this third option.
Fantastic. Let's then focus in a little bit on that one. So the end goal then is to take some existing sources of information, your health facility services database, to figure out how much homelessness is happening, to get an idea of where it's happening, who it's happening to, those sorts of things. So how do you actually do this? How do you use that hospital discharge data to look for cases of homelessness? Maybe this is sort of like the nuts and bolts of what did you do and how did you do it?
Sure. So we talked about kind of three things that were the sources of insight for how to do this. The first was, we're kind of academic in our bent, so we consulted research literature, read studies in journals and professional literature. We also relied on some practice wisdom. I'm a social worker, sort of in a former life, and worked in a hospital in settings like what I'm describing. I worked with folks who were experiencing homelessness and tried to find them a place to discharge to that was safe. And then we also talked to people on the ground who are doing this work, people who are hospital executives, physicians, nurses, advocacy organizations. We said, how do you define homelessness? What's a way that we could build this tool that you would want to use it? And those three things really did give us a starting point.
Yeah. So when it comes to the data, and I don't know which of you is the best one to answer this one, but what's in the data that would flag somebody as being homelessness for homelessness? Are there ICD codes, or how do you do that? Allison, maybe do you want to comment briefly on the technical nature of figuring this out from the data?
Sure. There's a couple different things that we were able to use in the data. In 2019, we began collecting, identifying information about patients so that we could, for the first time, assign a unique patient ID. And we were able to then use address information, just your street address information. And a lot of hospitals would actually type the word homeless or living in a car or something like that. So that was kind of one tier of it. There are also ICD-10 codes, diagnoses codes that are used for homelessness as well. And then the third one, which was Matthew's brilliant idea, was to actually look at the addresses of homeless shelters. And we found those constantly throughout the data and was able to use those quite a bit as well, because some of them in Kentucky have a mail, room, so these people can have a permanent mailing address. They have a PO box within the facility. So those were the main three. Matthew, can you think of anything I left out?
Yeah, those are the three legs of the stool. And we started thinking that the Z code, if you're familiar with the ICD coding system, that there is a Z code that is a physician can say, this is a patient who's experiencing homelessness. We originally thought, well, a lot of times you can't bill for that, so we didn't think it would be very prevalent in our data. Well, when Allison goes to run it, turns out that's the most helpful source, and it's where most of the sort of the meat of the indicator came from.
All right, well, let's take a look at some of your data then. Got here, so just some demographics. So once you've used those data, you've flagged patients as being homeless. What's the first thing that you can tell us from this table? What did you learn about them?
The first thing, so when I saw this data, I thought we're on the right track. It squares with, so to go back to those three sources of insight that we thought this is consistent with research literature. It's consistent with people who work with this population. And it's also consistent with sort of what I had seen personally. And so what, really the highlights are, it skews male. It tends to be disproportionately male. Kentucky's demographics are, depending on the time of the year that you cite from the census, it's about 86% white or Caucasian, which is a little bit off here. And we're going to talk more about, we did some statistics with race data in this, but more or less consistent with the demographics of the state. The people that the indicator identified were who we would have expected it to identify. It's predominantly middle-aged or slightly older men. And the primary health insurance, like I mentioned before, are from public sources, tend to not be commercial because these people tend to not be working or insured through an employer. It's mostly Medicare and Medicaid.
Okay, so let's check over your total. So you found 4,162 who are flagged as homeless. And let's just go ahead and put up this next slide here. How does that square with does that sound like the right number?
Yeah. So what's really interesting is that we did not set out. We found a paper from Illinois where Illinois said, well, what if we used a different source of information, or the same sort of hospital discharge data just for the state of Illinois, and said, what does that say about the prevalence of homelessness in the state of Illinois compared to what, if you're not familiar, that's HUD, Housing and Urban Development, does a methodology where cities and local areas will just collect volunteers and go out and count people. They'll count people in the shelters, count people sleeping outdoors, and they'll say, they'll index grant funding against that often. So we were not actually trying to do the same thing Illinois did. We just wanted to say who was homeless when they were in a hospital and identified in some way through the clinical, sphere. Well, it turns out that there's probably a high degree of overlap between people who are identified this way and people who go to hospitals, because the two numbers were within a few percentage points of each other.
Fantastic. I also just want to remind our audience that we do have the chat available for questions and comments. We would encourage you to put comments as we move along, and we'll address those near the end, but having those teed up will be very helpful to us. So table 2 you've given me. What's the one thing we learned from this table? Why are people in the hospital in the first place? What's causing them to go to the hospital?
So when we saw this table, we thought more of saying, this is telling us what we would have expected to see. And so it gave us increased confidence in this indicator as a sort of valid count measure. Because one of the most commonly observed things about the group of homeless folks who come to hospitals is mental health conditions, psychiatric conditions. So we found easily the top 2 most prevalent reasons people come to the hospital is for psychosis or for alcohol and drug issues.
Okay. And then are hospitals successful in treating those issues, or are they seeing them come back with readmission rates?
We used this analysis, we used this indicator to do that analysis, and found that this was another thing consistent with we looked at some studies that have been done by Yale and in New York City, and found that the rate of readmission within 30 days among this population is, depending on what the reference point is, about twice as high. So 30% in the Jefferson County or the Louisville metro area, the biggest metro area in the state. So no, there's a readmission problem.
Okay, and I guess that ties back to kind of what you're getting at here, which is if you don't have a place to discharge people, they're not getting follow-up care, then they come back. You'd mentioned earlier race as being a little bit off from the population averages. So let's look at table 3 quickly. I see an odds ratio there of 1.699. So what does that mean in terms of race and the likelihood of being in the hospital?
So this was another just way that Allison mentioned, being able to say, we don't have people's names or identifying information in that degree, but we had, this is the same individual. And so it allowed us to say, well, how many individuals of each race were admitted and how many were identified as homeless? And what we found when we just did a sort of simple unadjusted odds ratio was that a Black patient was at about 70% greater odds of being identified as homeless compared to a white peer in a hospital setting.
So it sounds like that while maybe your Black population isn't as large as some of the other states in the South, that there's a significant issue with them in terms of getting into the hospital. Let's go ahead then and kind of, we have 5 minutes to go, and I hope we have more questions from the audience, because I have a ton of questions myself, but I want to hear others' questions. But how are you using this work to help the people of Kentucky? What's actually happening on the ground because you're able to collect this data?
So one of the parties that approached us were people affiliated with the University of Louisville in Louisville, Kentucky, which is why I kind of keep referencing them in the answers to your questions. So there's a research team. There's an executive in residence they have in the School of Public Health. So it's former healthcare administrators who are trying to work on this issue. We found that this data is useful for them in their outreach efforts, going around the state and saying, here's an indicator that our office, the Health Data and Analytics, put together. Does it square with your internal data? So we don't know this, but they can see what you can go hospital by hospital and say, here's how many patients were identified in 2019. How many do you identify if you use the same methodology? And so the long story short is, we are trying to see if the economics of this problem work in a way that when a patient is admitted to a safer, more appropriate facility, this group here, Family Health Centers, is saying, we're going to make a space for them. And we're going to beef up what we have to offer so that when someone needs to be discharged from a hospital, they can come to us. And then we're going to do data linkage efforts to say, if that happens, does it produce an economic benefit to the healthcare system that is sufficiently large, reinvest some of those savings to keep the facility's doors open, to keep providing this service to patients?
So we do have a question from Mandy. Have you published your results or your methods yet?
We have a manuscript that we're developing that we're going to send to see if we can shop it around to journals. But in the short term, we do have our website published a method, sort of brief one-page overview of what we did, and it does say sort of those three major points.
So there's a white paper or working paper version available for people who want to read the full details, but formal publication is still TBD a little bit. All right. I also noticed in the notes I was looking at that the data is being used to inform choices about locations, because one of the things that we didn't talk a lot about, but you have data that is geocoded. So tell me a little bit more about how that would work.
So this is another thing that when I approached that question, Allison is the one who used the GIS software to geocode. And when her methods kind of produced the result, my first instinct was remembering my time spent working in hospitals and seeing that Kentucky is largely a rural state, and it has major medical centers in its metro areas. And I imagine this is fairly similar to folks who are also on this call in the audience. And so people will often, even when they're experiencing homelessness, they may want to choose to be in one of those outlying counties, and they'll be sent by EMS into the metro areas. So I'm from Louisville, and so I saw this happen a lot with the surrounding counties. And so to inform the sort of geography question, we would say, well, do you have to yoke the medical respite facilities to where the large medical centers are? And I think the answer is no. I think that these facilities don't have to be expensive to operate, especially if they're taking care of patients that don't have severe medical needs. A lot of times it just needs a bed and a roof, some food. And, we said one time that it's just bed, a room, some food, and love. And that's it. and just a place to recover. And I think especially because of telehealth and what we've all experienced with the pandemic, how actually there are models that work very well with reaching patients with telehealth, that these things can be distributed throughout the state and don't have to be clustered in the metro areas.
All right, well, we are pretty much at the end of time. I've put on the screen here a link that links to your cabinet. I hope I got that right. chfs.ky.gov. For people who want to learn more about this, they can go to that website and find information about the project. Or Matthew and Allison will be around. If you can connect with them through the Socio platform, track them down, send them emails or videos. I'm not exactly sure how to describe how Socio works here. We're getting used to it. But track them down and ask them questions. Look for them throughout the conference. With that, I think we are at the end of time, and I want to thank you both for your time with us today. We will record this. It'll be available back here within about 24 hours or less. And so anybody who missed it, if you have friends that weren't able to be here, please refer them to come back and take a look at it. So thank you, everyone, and we'll see you again next week for our third Igniter session. We look forward to seeing you here.
Thanks.
Thank you, Norm.